Thank you. So now we switch gear. We go back to PET PSMA on the specific question on monitoring patient on PSMA radioligand therapy. And we are pleased to welcome Dr. Andrei Iagaru.
Thank you very much. Thank you, Stefano. Thanks to Ken. Thanks to the organizers. It's a pleasure to be here. First time at APCCC, hopefully not the last one. So I'll take a little bit different approach. I will tell you right away that actually I don't know what is the best way to monitor patients on radioligand therapy. But I'll share with you data that we're collecting and what's in the literature. And hopefully together we can make an educated decision as how to move the field going forward into being better with treating physicians. And I'm a little bit taken aback that we talk about ctDNA and biopsy and PSA instead of talking about how we put all of this together, because I don't think that any single tool will give you all the right answers. These are my disclosures. So I'll try to take you through this pendulum swing. There are people who say no imaging is needed. There's probably a lot of imaging, and I'll admit to doing some over-imaging currently, but we're doing this in order to learn what is the appropriate imaging. And I think that this should be the goal for us. If we are to guide the quarterbacks, whether urologists and radiation oncologists early on, medical oncologists later on in the course of disease, they need answers from us. And right now we have to admit that we're in the process of figuring out what is the appropriate imaging for patients on radioligand therapy. So if you talk about no imaging is needed, and that can be PSMA or something else, one argument is since so many patients met the criteria and vision, why do you even bother? I'm appalled by that thought, I have to say, because I live in this space of, you see what you treat and you treat what you see. But there are some legit arguments about imaging being complex, expensive, may limit access to care, unproven outcomes. And I'll try to convince you of everything on the other side, that I think it's undisputed that you should know what you're treating. I don't think that any surgeon would cut without knowing the extent of disease. I don't think that a radiation oncologist would radiate without knowing the extent of disease. So why is what we do different than that? We need to have access to as much information as possible to make an educated decision. Cancer is so complex, it's such a cliche, but it is complex. So the more information you have, the better care we'll provide to those patients. And if you think, oh, imaging is expensive, perhaps at the beginning, but the cost of the therapy and the cost of failing therapy is much greater than the cost of a single scan before you decide to treat these patients. And in the end, it still remains a tiny fraction of the cost of the cancer journey of a patient, what you spent on imaging. And if that gets you good information, I think it's not wasted resources. And my friend and mentor, the late Sam Gambiri, used to have this very nice TED talk talking about molecular spies. So let's not be afraid of our molecular spies. Let's release them, send them in the patient's bodies, and let them tell us where the disease is located. Whether it's an enzyme that happens to be 90% of prostate cancer overexpressed, but also in other tissues and cancers, as we heard earlier, or it's as simple as glucose metabolism. We need to know what's going on in that patient and how that cancer is acting, because only then we'll be able to tailor our treatment to what they need. The other thing is patient access. And if you have time, go to the IAEA website. You'll be able to put any region, any country, and it'll tell you how many CT, MR, PET, SPECT scanners are there. So, slightly more availability of SPECT than PET, but they are there, especially in places where radioligand therapy is available. There's no shortage of scanners, and there's no shortage of experts to interpret those images. And also, we can do very, very well as far as time. It used to be that to do a SPECT-CT, it will take up to 40, 45 minutes. And I know, Luis, you do it in 20 minutes, but what if you can do it in 4 minutes? We eliminate the excuse of SPECT takes too long. Sorry, Nina, it's a fraction of the 45 minutes. So I think that advances will keep coming our way, and we need to not be afraid of advances in science and in technology, and we should use them to our advantage. What about cost? And these are not Stanford charges. These are what CMS will reimburse you, so government insurance. So don't take pictures because maybe mean nothing. It's just a matter of what proportion of what the cost of FDG versus the rest of things are. So if you add an FDG to properly select your patient, it's less than 1% of the cost of the drug itself, if you can give 6 cycles Okay, let's just think about that. Less than 1% to perhaps save you a lot of money and toxicity, which is not just labs, it's also financial toxicity for these patients who have to pay a lot of money to get treated. So I think that imaging, if you're honest about it, is not the largest contributor of cost to cancer care. And another myth that CMS, so government insurance, doesn't pay for FDG PET. It actually does pay. It doesn't pay at initial diagnosis, which makes perfect sense. Most of those cancers are not evidence there that in more than 40% of these was in change in management, that the government in the US pays for an FDG PET at recurrence. So if it's paid, if it takes little time, why not use it? And Michael, you're here, can't believe it's 5 years since you presented this data. You know, unfortunately, it's not in the label in the US for Pluvicto for lutetium PSMA 617, but I think it's very valuable, and we should take advantage of the knowledge that you and your colleagues put together in what is an ideal patient and what patients should not get treated with radioligand therapy. And then also, since you're talking about good data, this is Luis's data about SPECT being done at 24 hours, showing that after one cycle, you're able to predict the response and progression-free survival in patients. And this was replicated by our colleagues at UCSF, Tom Hope and his colleagues doing the same thing at 24 hours. But I don't think that 24 hours is the right time in a workflow where patients don't want to come back. In US, they go home within an hour, and parking is expensive, traffic is expensive, they don't have to be admitted. So Luis moved in the direction of doing SPECT at 4 hours, and it's convenient, cheaper, and the alternative to the 24 hours. So thank you for doing that. But what is our current workflow? So this is what we do at my institution. We try to do FDG and PSMA to select patients for radioligand therapy, and then we scan after each infusion because there's value added by that SPECT that's done, as I said, in very short period of time. Do we over-image? Perhaps, but we do it because we want to learn how to use imaging in the best way to assess response to radioligand therapy and to monitor these patients. And we learned that if we image, we find out things that we would not have known if we didn't image. So these are similar cases to what Michael has shown at ASCO 2020. Those patients with a red mark should not get radioligand therapy. And if we didn't do FDG, some of them would have qualified based on vision criteria. And then, of course, I have to admit that if a patient is in front of me and they met the criteria for vision, it's difficult to tell them I'm not going to give you the treatment. But if you have a case like the one in the bottom right, where there's very little, if at all, PSMA-positive disease, and FDG is extensive, I can't convince myself to give radioligand therapy to that patient. And this is a typical course of patient. The scanner didn't work after cycle 3, so I don't have that image, but you can see response. So if it works so nicely every time, why even bother doing it? Well, because sometimes things happen that shouldn't happen. Like in this case, the dosage of radiopharmaceutical has extravasated in the antecubital fossa. And if we didn't image, we would not have known. If we imaged at 24 hours, we would have not known. But now that we know that there is extravasation at the injection site, we tell the patient, lift your arm, put a warm compress for an hour, put cold compress afterwards, and it will resorb by the next day. And this is going to be a publication from my colleagues who was shown at RSNA last year, demonstrating the complications after infusion. And there's also predictive value from these scans that are done at 1 hour. So we image at 1 hour post-injection. And it's my colleague Hong Song showing that the volume of PSMA-avid disease and the decrease in this volume is predictive of outcome. So we're not doing it just for the sake of doing it. Now, it also allows us to decide when to stop and why to stop radioligand therapy. In this case, after cycle 2, there's some funny appearance on this very fast SPECT that's done 1 hour after infusion. And because it didn't make sense, and we don't look just at these images on their own. We talk to our colleagues in medical oncology, we look at laboratory data, we actually have a trial looking at ctDNA done during the course of RLT. We ordered an FDG, and that showed disease that was in a totally different pattern than the PSMA-avid disease. So what is the point of continuing radioligand therapy here when you have new lesions that are not expressing the target that you're going after? It's another patient, again, good response up to a while, but the PSA was going in the wrong direction. We did a PYL PET, not too impressive, but then the FDG PET was impressive. Again, why continue treatment with RLT when you have new lesions that have a different biology? And if you don't scan, how would you know that? And the opposite of this is complete response. So if there's no more imaging on SPECT and then confirmed by PET and have PSA 90 decrease and the patient is doing great, why not stop? Give a patient a holiday. We're not curing these patients. So save your radioligand therapy for later on when they truly need it. Here's another example, same thing. A lesion disappeared after 2 cycles, so why continue the treatment? Why not have a consultation with the oncologist, check the labs, talk to the patient, see if they're comfortable, stop. And the opposite, why not extend radioligand therapy? We now have data, retrospective, but data that is promising, data from Germany showing that you can give actually many more cycles as long as there's a continued response and the patient tolerates this well. So I hope that I convinced you that both FDG and PSMA PET provide useful information. I think that PSMA SPECT is very valuable. We don't bill additionally for it. It's part of the treatment. We just do it before the patients go home. So our goal is from arrival to the clinic to departure, 90 minutes. And that includes infusion as well as the SPECT CT. There is an upfront cost, but it's much less than the cost of treatment. And then the more information you have, the better we are. And I have to admit, the appropriate sequence of imaging and what to do best, we're still learning about that. But if we don't have the data, we're never going to learn. And with that, these are my colleagues, more than 90 people in nuclear medicine at Stanford. And someone said yesterday, why don't we have a more diverse patient group being recruited? Well, I think you're going to have a more diverse patient group being recruited if your team is diverse, because diversity attracts diversity. And I encourage you to do that. And tomorrow is Spring Day in Romania, where I'm from originally, and this flower is a symbol of spring. And so I want to wish you all a very happy spring 2025, and thank you for the invitation.